second.
Okay, beautiful. Thank you.
So Dr. Kessler is going to enlighten us on GERD. It comes from an institution with a long history of interest in endoluminal control of reflux disease.
Great. Thank you for the invitation. Stavros, wherever you are. Thanks for introduction, Dr. Gustout. And again, I'm Bill Kessler. Dr. Lehman and I flew out here from Indiana University yesterday to kind of give this talk, and we flipped a coin and I won, and I get the chance to do the talk. So happy to be here. The financial or the conflict of interest, Dr. Lehman has none, and I speak or used to speak for Takeda Pharmaceuticals as a speaker. GERD. GERD is very common. It's not nearly as exciting as ESD or POEMS, but GERD, we see it every day in the office, and I imagine you do as well. So it's defined as a condition which develops when the reflux of stomach contents cause troublesome symptoms and or complications. Typically, PPIs are where we're at in the year 2015. A large percentage of the country is on them. We know that 20 to 40% of patients have an incomplete response. We also know that over the last couple of years, the labeling has changed on the PPIs to the point that we have to have conversations with our patients about concerns for calcium absorption and osteoporosis, absorption of other things such as vitamin B12 and iron, infectious risks such as C. diff and community-acquired pneumonia, drug interactions such as with clopidogrel, and then finally we have to keep in mind that high-dose PPIs are not FDA approved for long-term use. Surgery has been the mainstay for patients who are refractory to high-dose PPIs, and the considerations are for patients, again, partially responding, patients intolerant to medications, or patients that would prefer surgery over long-term use of these medications. The goal is to improve the structural components, and it's best for younger patients with typical symptoms who respond completely to PPIs. And 5-year follow-up and even longer for surgical intervention is very good. Vast majority of patients have symptomatic improvement. Dysphagia is about 10 to 12%, with a 10% reoperation rate. And there's very strong data that the pH improvement from 8.5% to 0.7%. The lap Nissen is the standard surgical approach, and this was 1991 is when this became kind of the mainstay. Very good, but the conversation with our patients isn't that once you have surgery, you're off PPIs. Rather, we know that when you follow patients out 7, 10, 12 years, probably 40 to 50% of patients are back on their proton pump inhibitors. We also know about adverse effects. You see your patients in the office, and they talk about gas bloat syndrome, dysphagia, etc. So the thought, looking back, here's an article of 2013 looking at a 180-degree wrap rather than the 360 conventional wrap, and to see if it was as effective and even with fewer side effects. And looking at this table, you can see that PPI use was reduced significantly in both, or there was no significant difference in terms of PPI use post-surgery. We know that the symptom control and general satisfaction were very similar. And then some of the side effects, such as flatus, difficulty belching, were seen more often in the standard surgical approach. So with that in mind, why are we talking about that? We're talking about it because of the topic here is endoscopic therapies for GERD. So GERD is common, surgery is good but not perfect. Endoscopy has replaced surgery for other indications, and I don't need to give examples after this morning's presentations. And the ideal endoscopic therapy for GERD would be safe, effective, it'd be user-independent, and economically viable. And it's judged by the same criteria that surgery is. So symptom relief, reduction in use of medications such as PPIs, and then objective improvement, such as improvement in esophagitis, pH, as well as lower esophageal sphincter pressures. So why are these not taken off? As it's been mentioned, these have been talked about for years and years, and they're still not the mainstay. And it's a few reasons. Suboptimal efficacy, side effects, some of which are serious, and we'll talk about those briefly. Lack of useful codes, and this is something that comes up time and again. And then the relatively high cost for the achieved efficacy. So again, the topic or the title of the talk is Past, Present, and Future. So in the past, many devices have come and gone, but here are a few that were listed. the Endocinch as well as the Endio plicator, which were both plicator-based therapies. Both had pretty good efficacy. Some side effects with Endocinch involved bleeding from submucosal ulceration that occurred post-procedure. And then with the Endio, there's a fair amount of diaphragm-related complaints, chest pain, shoulder pain, etc. Both of these had been removed from the market. Enterix and Gatekeeper were both injections, and both of these had pretty good efficacy. These, in particular, Enterix was relatively commonly used, but there were complications including mediastinal and mediastinal abscesses as well as emboli. And migration was a problem with Gatekeeper, so these also were removed. Again, one familiar name, or at least on the publication here, Dr. Gestout was part of the Endio study. And this is 2-month follow-up, and this is from GIE 10 years ago now. And there was a significant improvement in GERD, HRQL scores. 2/3 of the patients were off PPIs, and that's about what typically is seen. A 25% drop in pH exposure. Demeester score had dropped by approximately that same amount, and the main complaints, again, were thought to be shoulder, back pain related to diaphragmatic irritation, and sore throat is common with a lot of these procedures because they require relatively good-sized devices. That was just a couple of things that allow that to no longer be available. It mainly comes down to the coding for this device. For a company to come up with the concept and have it paid for, it has to have a fair amount of capital behind it. And a lot of these companies have come and gone because that's not been the case. Enterix was an injection at the GE junction, and this was performed under fluoroscopy. And this is a cross-sectional imaging study just showing the proximity of the esophagus, which is our target site, with the left atrium and the aorta. And due to the proximity of these structures, there were complications, again, including mediastinal perforation with abscess, aortic embolization, as well as aortoenteric fistula. Currently available therapies include the Stretta device, which is a radiofrequency therapy, the TIF, or Esophax 2, as well as the Medigus system called Muse, formerly known as SRS. In terms of the strengths of each of these, Stretta has a relatively long-term data, up to 10 years. This has that's a strength. Limiters include the reimbursement. You'll see that for each of these devices. And Stretta has a code, but it's not been extremely successful in terms of reimbursement for using that code. For Esophax, it's a plicating device using H fasteners. Strength is experienced, but again, reimbursement is listed as a limiter. And then for the Muse procedure, this is a relatively new procedure. It's another plication. The strength is that you have ultrasound guiding where you place your staples, and the limiters are, again, small series, as well as, again, reimbursement. All of these therapies could potentially benefit from further studies on dose, how many therapies, how many staples, how many fasteners, as well as longer-term follow-up. Just within the last 2 weeks, I believe, or 3 weeks, the AMA announced that there is a code that will now be available for endoscopic fundoplasty, and that's the code listed below, and it'll be available January of 2016. So this may take care of one of the main limiters that I've spoken about. With Stretta, again, radiofrequency therapy to the GE junction. This is performed with thermocoupled needles, and approximately 50 treatments are performed. The actual mechanism by which this is effective is interestingly still debated. Basically, the thought is that by thickening the GE junction zone, or the lower esophageal sphincter zone, this leads to reduction in acid exposure. There's theories such as if this is inflammation followed by fibrosis, if this is some form of denervation of the lower esophagus. And we know that subjectively patients improve at this, and there's not quite as compelling of objective data. Here's a 4-year study going over patients who've been treated with Stretta. 59 patients followed. No major complications, but approximately a quarter of patients experienced self-limited chest pain. About 3/4 of patients off of proton pump inhibitors. Objectively, erosive esophagitis healed in all. There was no change in lower esophageal sphincter pressure, and there was no pH data or controls in this study. Again, the main adverse effects are the chest pain. There's also some concern about gastroparesis for patients related potentially to vagal nerve injury. Esophax, this is a picture of the tissue mold of the device, and basically what you see here is the mold that allows retroflexion as well as creating the angle of His, the H fasteners that are applied here, and this is a device that's applied after a standard endoscope is passed into the stomach. So basically the standard endoscope is inserted, the stomach inflated, the device inserted, and then with the tissue retractor you can pull down that fundus in order to fire these H fasteners. Here's a picture pre, post-op, and then 4 weeks later. Here is a 2-year study, surgical endoscopy, 2012, 42 patients treated with 12 fasteners, and they had all had at least 2 years of follow-up. There's significant improvement in their GERD HRQL scores, minor improvement in their lower esophageal sphincter pressure. Demeester score was relatively unchanged, as was the absolute number of refluxes. The TEMPO was a more recent trial, and looking at patients who had partial response to PPIs, and patients were randomized to TIF on no PPIs versus continued on high-dose PPIs. And as you can see, almost all patients had significant improvement in their chronic regurgitation symptoms, whereas approximately half of patients had improvement while on high-dose PPIs. In addition, these are graphs or figures looking at the GERD HRQL scores, and you could see a significant improvement in the group randomized to the TIF. So across the board, about 9 out of 10 patients were off of PPIs at 1 year after or 6 months, after TIF. And the healing of erosive esophagitis was that same percentage, 90%. Main side effects listed there, again, rare esophageal perforation, pneumothorax listed as well. But the overall complication rate was relatively similar to that of Nissen fundoplication. Finally, the Muse device, basically here is a very similar symptom. It's a full thickness plication, in this case using staple quintets rather than these H fasteners. Here's a picture of the endoscope, and we'll have a chance to use this in a little bit on one of the patients. And basically, again, the main feature with here, this is a disposable endoscope that's initial endoscopy is performed with the standard endoscope. Next, the Muse is inserted, retroflexion is performed, and then there's an ultrasonic signal that's actually captured, and that allows you to know where that staple is actually going. That's one of the concerns with the TIF procedure, is that the number of fasteners, you can't guarantee that they're ending up on the other side of the esophagus. Here's a picture from our institution a few years back, and this is pre and post procedure, so you can get a relatively good Hill grade there, or flap valve. And here's a study we had the opportunity to participate in with 6-month data from a multi-center study looking at patients treated with Muse. And the total scores for HRQL improved. There's also improvement in use of PPIs, and then finally their pH exposure improved. Number-wise, it wasn't that dramatic, from 10.9 to 7.3%, but this was statistically significant. In terms of adverse effects, in the first third of patients, an interim analysis was performed at that point, and there was a higher risk of complications, including pneumothorax, pleural effusion. There are a couple changes to the protocol where patients all received scheduled antiemetics, and some positive pressure was applied during the procedure in the form of PEEP, and this led to a significant reduction in the complications. Here's yet to be published, but this is now 4-year data from multi-center trial on Muse, and you can see there's improvement in GERD HRQL scores. The number of patients is approximately half of what started the trial. So where do we stand in the current day? There's kind of 2 balancing opinions. On the top is an editorial by Dr. Pandolfino, basically stating that the current data does not support the risk-benefit of endoluminal therapies versus the current management paradigm of GERD. On the other hand, at SAGES 2013, there was support for, at least in this case, for STRETA in patients who are acceptable candidates. So the future options, about 5 minutes left, does that sound right? Okay, future options, we have bands, magnets, and stimulators. A couple of these things were actually mentioned earlier today. But first I want to get to this. This was the concept of forming small strictures in the distal esophagus in the hopes of increasing or bulking up the lower esophageal sphincter. We know that when we do endoscopic therapy with band ligation or endoscopic mucosal resection, we cause scarring. And we know that as the circumference, percentage circumference involved increases, the stricture rate increases as well. So the concept was to create multiple focal scars down at the distal esophagus as well as the proximal stomach. And this is something that we had the opportunity to publish or to present in DDW 2013. Small study, 5 patients randomized to banding, 5 patients randomized to banding with endoscopic mucosal resection. And patients had basically 7 to 8 treatments performed right around that lower esophageal sphincter. Patients were followed out to 12 years. And here's a picture of a patient who underwent the banding procedure. This is looking down at the distal esophagus. Similarly, he had had 4 bands placed at the proximal stomach. And then here's a patient who had undergone band placement as well as endoscopic mucosal resection. So these patients were followed, and in terms of their HRQL scores, these improved significantly from a mean of around 25 to 30, and then looking at patients at 12 months, the reduction was down to approximately 10. And looking at PPI use, this dropped dramatically as well. And we also have patients that have now been followed out to 3 years, and it's approximately half the patients have been followed, but you can see the results have been relatively stable going up to 3 years out. Positives would be that there's no capital investment, there's no specific training to do this procedure. It's performed under max sedation with patients going home the same day. Dose escalation is a possibility as far as the number of bands or the number of zones that should be treated. And then other options such as surgery would still remain an option. The downsides were dysphagia. It was relatively common for patients who underwent EMR treatment, and there's only pilot data available. Very briefly, LINX was touched on earlier by Dr. Gestout, and this is a laparoscopic procedure that's performed, and it's really has a lot of promise. Again, this is performed laparoscopically, and the thought is that with these titanium cases with the titanium ring, these magnets expand and contract to allow food to pass while also cutting down on acid exposure. In this single-arm study of 44 patients, there were no major complications. The surgery took 40 minutes, and patients who experienced dysphagia that typically resolved within a short period of time. Basically, this just shows improvement in their HRQL scores, improvement in their pH, as well as Demeester scores. So again, this is something that we're not doing endoscopically. It's a laparoscopic procedure. I had no idea how I was going to tie that into my talk until I heard this morning's talk, and it sounds like they're already working about it up at Mayo Clinic. Finally, EndoStim. This is a subcutaneously placed stimulator with leads placed in the lower esophageal sphincter. The battery life is 10 years, and small studies have been performed on this showing improvement in the lower esophageal sphincter pressure as well as HRQL scores. Here's, I'm sorry, a tough to see slide of that, but HRQL at baseline approximately 25, and it dropped to 2 at 6 months. Demeester score improved, though not significantly, from 33 to just about 12, and improvement in the lower esophageal sphincter pressure from 8 to 16. There's also significant, just significant improvement in pH exposure. So in summary, GERD is common. PPIs and surgical options are available, and they're pretty good. Endoscopic therapies are moderately effective, and we certainly need additional studies to optimize the number of doses as well as longer-term studies. And the suitable reimbursement coding has been an issue for a long time. With this recent announcement, hopefully this will allow us to pursue these options a little more thoroughly. And finally, reduced adverse events are certainly desired. I thank you for your attention, and I think we'll do the question and answer now.